So in patients with disproportionate pain, systemic symptoms, and hemodynamic compromise, you need to think about necrotizing soft tissue. All right, so there are some risk factors for you to read as well. Right. Okay, for psychiatric illness, all right, it's important for you all to know that the commonest are depression and anxiety. So this can actually come out as your MCQs. Depression and anxiety are the commonest mental health problems, right? And in psychiatric illness in pregnancy, you need to know that psychosis can be exacerbated during pregnancy and postnatal period. And postpartum psychosis is between 1 to 2 in 1,000. Okay, all right. And which disorder has got higher rate of recurrence? Usually it's the bipolar, right? Now, for chronic, for psychiatry disorders, okay, depression and anxiety again is the most commonest illness in pregnancy. Okay, there are few things like, for example, SSRI drugs are the first choice in general population and widely used in pregnant women. Okay, there is risk of having persistent pulmonary hypertension in those who are okay, and you also need to be aware the cause of that drug to the pregnancy or to the babies, right? So you may have babies with irritable conditions, difficulty feeding and breathing, right? And there's higher risk of cardiac defects if you use certain medication called paroxetine. Okay, certain drugs that are safe, you need to identify. So make a checklist, right? So if I'm discussing about psychiatry in pregnancy, what are the questions that they can potentially ask me, right? Use of benzodiazepine can lead to floppy baby syndromes, right? Okay, you should avoid alprazolam, for example. Okay, so here lithium, if you use it in the first trimester, you get Epstein anomaly. So it's not Eisenmenger, it's Epstein anomaly, right? Okay, so when you're doing your reading, all right, look for drugs that are contraindicated in pregnancy. So this can be part of your MCQs, all right? Those with absolute contraindication, all right? Those has got teratogenic risk. Okay, beside them, right, what are the teratogenic risks that actually can happen to them? Okay, this aids the counseling for your patient in real life, or it will help with your exam, right? Similarly, if you're asked about MCQs on epilepsy, right, look for things like what are the problems that can happen to epileptic women taking certain drugs, all right? And women taking lamotrigine has got higher incidence of oral cleft, okay? All right, certain antibiotics have also got some relative contraindications. So this can actually come out as your MCQ, right? For example, nitrofurantoin has got G6PD deficiency. Discoloration of teeth occurs in tetracycline, gray baby syndrome in chloramphenicol, right? And things like if the patient is given a TB drug, streptomycin can cause ototoxicity, all right? Now, one of the questions of your MCQ had got inverted pyramid of care, right? So this is something new, okay? We used to see women less in the first trimester. We used to ask the GPs to see or clinic kesihatan, and we will start seeing them later. Remember, your bookings are all later. Now it's important that we see the patient early, 11 to 14 weeks, right? Exclude or do a fetal screening, exclude for any problems, and then subsequently we do a detailed ultrasound, look for evidence of whether the patient has got risk of preterm birth, and we see them in smaller frequency when they are towards their term. All right, so this is inverted pyramid of care, so you can do some reading. Okay, I'm not an infertility expert, but you need to have some general knowledge when you're sitting for MOG exam. you need to be able to have some general knowledge about how to do calculation. For example, you will see patients who have undergone IVF treatment, okay, and she has come and she will tell you, okay, when was my embryo transfer date? Okay, so if the embryo transfer date is 3 days, how to calculate? If your embryo transfer date is 5 days, how to calculate? So the general rule is 266 days from the days the eggs are harvested, right? So if it's a fresh donor cycle, right? So you calculate 266 days for her due date. 3 days transfer will be -3. 5 days will be -5 days, right? So this is a general rule, right? Okay, so some of you have got the first question wrong. Regional block extending to T10 dermatome is desired for cesarean delivery, right? So, and your question E, incorrect as well, right? So, this is a nice website, okay? I'll show you to you in a while to look for analgesia in labor and cesarean delivery. So, labor analgesia, if the woman is in first stage, when you're giving epidural, your target is T10 to 11, L1, right? In second stage, you want more of the reduced sensation at the sacral area. So it's S2 to S4. For Caesar, you want the anesthesia to go up to T4 to T6, right? So let's say the woman is having an epidural in labor, right? Initially it will be T10, then they will come up and top up the epidural for you to do a Caesar, okay? So that will go up to T4 level of anesthesia, okay? So this is a small guide, right? So your motor, sensory, and so motors and sensory. Labor, the motor supply is not affected, right? Okay, so for any uterine surgery involving the uterus, for example, cesarean, your sensory level need to extend to T4, T6. If let's say you are doing a complicated Caesar, then your level has to go up to T3, T4. So most of them will do a general anesthesia. Okay, now I'll just show to you. Okay, so this is a nice pocket guidebook on anesthesia. All right, so they have got physiology of pregnancy, postnatal, PPH, labor analgesia. What does it cover? Right. So this is a good website to actually go to. All right. Okay, now some of y'all have answered this question on mother to child transmission of HIV, right? So oral nephirapine is given to HIV patients, okay? And is it for fetal prophylaxis, right? So if a question asks whether oral nephirapine is given to HIV infected mother for fetal prophylaxis, the answer would be yes, right? So this is a question taken from your exam, right? Okay. Always look for Malaysian guidelines from there. So this is a management of HIV infection in pregnant women. Okay. There are some recommendations for HIV pregnancy when the count is less than 250, when the count is more than 250. I will not go through this. I'm just introducing merely to you. HIV in pregnancy, there are recommendations for mode of delivery. For example, when do you recommend Caesar? When the viral load is more than 1,000 copies, all right? When the viral load is less than 1,000 copies, the woman can opt for vaginal delivery, right? Recommendation for women diagnosed in labor, all right? So what are the prophylactic antiretroviral drugs that has to be given? Okay, once the membrane has ruptured, how long, right? And whether any vaginal disinfection may help to reduce transmission. So the answer is no. So all these small things can actually be translated into your MCQ or even EMQ, right? Postnatal care, contraceptions, okay? breastfeeding, right? There was a question on mastitis, all right? So there was two groups of answer. You all had conflicting answers. So you can to reassure the woman or infant, and you should encourage to continue breastfeeding, right? Now, when you're doing some reading, right? For example, you're looking at questions on breastfeeding. Look for drugs that are safe to continue breastfeeding. Look for drugs that are not safe. For example, if you're giving a high dose metronidazole, you need to discontinue breastfeeding, right? These drugs are contraindicated during breastfeeding, right? Quinine, usually you will, in some cases of SLE, yeah, or autoimmune. Okay, also look for vaccines, all right? Vaccines which are can be given in pregnancy, or those are recommended only after pregnancy. What are those contraindicated? So for the flu vaccine, I think many of y'all has put no, cannot be given, right? So flu vaccine has got two types. One is inactivated, one is live attenuated, right? So the live attenuated, of course, is contraindicated, but of course, in pregnancy, it is recommended for them to take the flu vaccine. So you got the injectable form and the nasal spray. Nasal spray is the live attenuated that is not recommended, right? So the injectable type you can actually give during pregnancy. Okay. There was a question on puerperal sepsis. Okay. What was the lactate measurement? So this comes from guidelines, right? So we took the answer from question from guideline. So serum lactate more than 4 indicative of tissue hypoperfusion. Okay. Now this is on tumor markers, right? So tumor markers in pregnancy, okay, you know it's not reliable, but what are the what is your reading on it, right? Which type of tumor markers and all that. So just now was comparison between HE4 and CA125. Okay, so a paper here has mentioned that HE4 levels rises significantly in third trimester, right? So there needs to be a cutoff value for you to help to diagnose, right? So this is a beautiful paper uh, uh, released in 2016 on tumor markers. So if you have a look, CA125, it can actually go up in first trimester, right? And if you, on the bottom of the screen, HE4, lower levels in pregnant women, mildly increase in third trimester. Okay, so it's nothing better than CA125, right? Okay, so this is a nice paper for you to read before you go for your exam, right? So we had a question on luteoma, right? So if you read, if you love to do some reading, or if you always help when you identify cases in the ward and do some case reports, this is a rare condition, luteoma. It secretes androgen, okay, 25% of them, and it creates maternal realizing symptoms as well as female infant realization. Okay. Now, also be very observant about what are the investigations that you're offering to the woman. For example, cell-free fetal DNA. All right. The clinical application. So one of the question was, it can be used to diagnose the fetal sex. Yes, that's true, right? Because it helps to detect Y chromosome, right? It can be used for single gene disorder. That's also true. Okay. All right. So if you see up to now, most of it is from guidelines. All right. So this is on cervical smear and pregnancy. Okay. So any form of bleeding, all right, you should be going for colposcopy, right? Now, this is on MDG. Please do some reading, okay, because this will be useful for your vivas. Okay, this is your MDG goal 4 and 5. So MDG 5, based on the same report, okay? Of course, Malaysia has declined by 50%, all right? But our target was two-thirds, right? Two-thirds, 75%, sorry, almost 66%. But we have managed to achieve up to 50%. So we have not achieved the target, right? And our maternal mortality rate is 28, all right? So maternal mortality in 20, all right? Your maternal mortality ratio should be less than 70. No country should have greater than 140. So the answer was not 200, 140. All right. So these are sometimes difficult questions to actually discriminate those who actually are slightly better students, right? Who do a lot of reading, right? Okay, this is a paper on comparison of myomectomy UAE and your MRI guided HIFU, right? So myomectomy has got the lowest reintervention rate, okay, while your MRI HIFU has got the highest, right? So your UAE is 10 to 20%, HIFU is 60%, myomectomy has got the lowest, right? So for this question, all right, some of the answers were in heavy menstrual bleeding, nice guideline, okay, right? So please do some reading. Okay, so this is on the alleged rape. I think I've given you the answer, 1 in 500. This is the guideline for you to read on emergency contraception, your FSRH guidelines, all right? So that's on levonorgestrel, copper. So all are effective between 5 days, all right? Okay, so for laparoscopic, all right, I think I've given you the answer. So pneumoperitoneum induces increase in the systolic pressure, right? When and should not cause any change in the pulse pressure. Changes in pulse pressure means hemodynamic, hypovolemic condition, right? Okay, there are a lot of guidelines on hormonal therapy, yeah? Okay, hormonal therapy. For example, there's a nice paper on menopause and hormone replacement therapy. Okay, what are the HRT regimes that we have? Okay, this is also a GP guideline, but it's a beautiful guideline, and it actually lists down what are the low dose, standard dose, and high dose, and different types of estrogen and progestogen. Okay, so have a look at that. All right, we're coming to endometriosis. Okay, so question E, yeah, most of you have got conflicting answers. So these are the classification of staging system for endometriosis. So if you have a look at Enzian, Enzian 2012, all right. So this is for deep infiltrating endometriosis, all right, deep infiltrating endometriosis. Okay, so this one is for your ASRM is for superficial, right? Superficial adhesions, including this is mainly on superficial adhesions and deep adhesion is classification of deep infiltrating endometriosis. Okay, don't forget to read on endometriosis fertility index. All right, so there are some scores on the assessment of the fallopian tube, fimbriae, and ovary. Right, something for you to read. Okay, twisted awarenesses. I think I've covered that. Okay, now we'll move on to EMQ. Okay, so I've got I've got the questions here. All right. So for EMQ, attempt as all the questions. All right. Okay. And this should be easier to score compared to your MCQ, because it's more clinical. So let's look at the questions. All right. So for this question, I think majority have got it right. A 31-year-old G2 Parawan at 24 weeks pregnancy. She's got a modified OGTT, all right? And sorry, I think she's got failure in a previous delivery, she's got failure to progress, and the baby's weight was 4 kilo. All right. Hang on, let me have a look at the. So that was, sorry. So a 31-year-old Gravida 2 at 24 weeks pregnant. Her second modified OGTT was 5.2. 2-hour postprandial was 8. History of emergency seizure for failure to progress, and the baby was 4 kilos. Right. So what was the answer? Okay, this is just her MGTT, yeah, right? MGTT. So following MGTT, we always advise for dietary, right? Just because her previous babies was 4 kilo, we don't go straight for insulin and things like that, right? Or you will need to do blood sugar profile, but before that, you need to ask to do diet control followed by blood sugar profile. Okay. So this patient had so this patient is 28-year-old Gravida 2 para 1 with diet control, GDM, okay, seen in the antenatal clinic at 30 weeks gestation and found to have symphysis fundal height of 32 centimeter. So her blood sugar values were increasing, right? In spite of good dietary restrictions, right? So let's have a look at your answers. Okay, so most of you all have answered metformin, right? So that's correct, right? There shouldn't be a need for you to go straight to insulin, right? Her blood sugar profile are still okay to start metformin first, all right? So metformin is the initial bit, all right? HbA1c is looking at the control, right? These are blood sugar profiles done at the it's like a cross-sectional test, right? So you need to start treatment. You only assess control once you have started on treatment. Okay. Okay. So this one, this is a patient with a previous history of stillbirth in a previous pregnancy and currently diagnosed with diabetes and on oral metformin, but she's been having very good blood sugar profile. Right. So once you have done treatment and the blood sugar profile is good, and she has got previous history of bad obstetric outcome, we want to assess her we want to do an alternative assessment of the control, right? So it has to be a HbA1c. You don't carry on doing a blood sugar profile without any form of assessment of the control, right? Okay, now many of you have got this incorrect, all right? This is a 34-year-old Gravida 3 para 0 with 2 miscarriages in the past. At 30 weeks, presented with productive cough and regular uterine contractions, all right? So you can't see the rest of the question. Or maybe I should go to the, hang on. Okay, so the estimated fetal weight was 1.6 kilogram with normal liquor volume. Vagina examination showed cervical dilatation of 5 centimeter. The CTG was normal with contraction of 1 in 5. All right. Now, it is recommended, all right, when the gestational week is between 30 to 34. All right. So let me share you my slide. Okay. So when the gestational age is between 30 to 34, okay, it's recommended to give neuroprotection, to use magnesium sulfate for neuroprotection. This is based on your Magenta study protocol, right? especially when imminent birth, all right? When early preterm birth is planned or definitely expected between 24 hours, right? Okay, so this is magnesium sulfate, until otherwise, all right? Okay, next one is on monochorionic twin with the previous scar, all right? This shows that the bleeding is known to be from the thick cervix with erosion, right? So even though clinically we do sometimes give antenatal corticosteroids and plan like that, but based on the question, the reason for the bleeding is revealed as local cause, right? So the answer will be conservative management, right? Okay. Now management option for ovarian mass, okay. Uh, a frail 90-year-old woman presents with abdominal discomfort. Okay, ultrasound reveals a simple ovarian cyst. CA125 is 20. All right. So when ultrasound is simple, CA125 is 20. All right. So what is we follow some guidelines. All right. So we can follow a RCOG guidelines when the mass is a simple, okay, simple mass. All right. But it's large, you need to rescan in 4 to 6 weeks. All right. Okay. So the answer will be rescan in 4 to 6 weeks. Okay. Now, if you suspect the mass is malignant, all right, malignant, even though in a frail, in a older population, 65-year-old woman, okay, and you suspect the mass is malignant, for any ovarian mass suspicious of malignancy, surgery is the answer, right? You always go for surgical options, all right, okay, rather than we don't do a radical hysterectomy for ovarian mass, right? Okay. And of course, you are not going to keep the uterus in a older patient, right? And we do not have any reason to do chemotherapy because this mass, it's just mentioned ascites. It doesn't say that ascites peritoneal fluid is positive and you know, CT scan shows evidence of upper abdominal disease. So chemotherapy is out, right? Now, for polycystic ovarian syndrome, okay, many of y'all has got the answer correct, okay. So this is a patient with primary infertility, PCOS, has had 5 cycles of clomiphene citrate, failure to ovulate, and persistent hypersecretion of LH, right? Now, if you continue, this is called clomiphene citrate resistant, right? So the next therapy would be a advice for ovarian drilling, right? Because her BMI is okay, not too bad, right? This is an obese patient, 4 years secondary subfertility, all right? And she has conceived first time with clomiphene citrate, right? In the past, all right? But this is a risk factor to develop OHSS, right? Okay, so you need to advise for weight loss. So we have a look at our evidence, okay. Lifestyle improvement, all right, okay, always remains the first line approach, all right? Even though she has responded with clomiphene in the past, again, lifestyle approach, all right? So this is a good paper to read. When do you use metformin plus clomiphene citrate? And in those patients who has not responded to clomiphene citrate, what are the next steps? All right, so one of it is ovarian drilling, right? Okay, last, this is a young girl, right? With symptoms of hirsutisms, all right, irregular menses, and her BMI is okay, all right, not too bad, right? So what can you advise, all right, in terms of her symptoms? So when she's got hyperandrogenic activity, we advise for oral contraceptive pills that contain ciptorone acetate, right? So this comes from a a guideline as well, long-term consequences of PCOS. All right. Okay. Thank you. Any questions?
I think there is one